Thyroid Gland and Anesthetic Management. Daniel Stairs CRNA, MSN, MBA. Excel Health School of Anesthesia. Thyroid gland is H-shaped right and left lobe with isthmus. Location of thyroid gland. Anterior to trachea. Just below cricoid cartilage. Covering 2nd through 4th tracheal rings. Thyroid gland weighs about 20 grams. Blood supply to thyroid gland. 4 to 6 cc per minute/gm. Arterial supply via inferior and superior arteries. Venous supply via inferior, middle, and superior thyroid veins. Nerve supply. 2 superior laryngeal nerves and 2 recurrent laryngeal nerves supply the entire sensory and motor innervations to the larynx. Innervation. Recurrent laryngeal nerve. Most common nerve injured in thyroidectomy. Motor supply. Sensation below vocal cords. With selective injury to abductor fibers. 1. Hoarseness. 2. Bilateral injury. 3. Obstruction, recurrent laryngeal nerve. Selective injury to adduction fibers. Postoperative assessment after thyroidectomy is by laryngoscopy and having patient phonate letter E. Most common nerve injury, superior laryngeal nerve. Motor supply to cricothyroid muscle, SL and external branch. Internal branch provides sensation above the vocal cords. Injury causes possible risk for aspiration and hoarseness. Essential thyroid hormones. Thyroxine, or T4. Triiodothyronine, or T3. Release of these hormones into circulation stimulated by TSH. T3 is less firmly bound to carrier proteins and disappears from circulation quicker. T3 is 3 to 5 times as potent as T4 but is limited by its transient nature. Thyroid hormones. Nearly all circulating T3 is derived from peripheral conversion of T4. Major functions of thyroid hormones. 1. Calorigenic effects. 2. Growth and cellular differentiation. 3. Metabolic effects. 4. Muscular effects. Other functions of thyroid hormones. Working with growth hormone, they ensure proper development of the brain. Increase protein breakdown and glucose uptake by cells, enhance glycogenolysis, and depress cholesterol levels. In excess, they may interfere with ATP synthesis and thus speed the exhaustion of energy in muscle tissues. Thyroid hormones. Thyroxine normal serum range is 5 to 12 micrograms/dl. Triiodothyronine. Normal serum range is 70 to 90 nanograms/dl. Laboratory testing of thyroid hormone. 5 general categories. Direct tests of thyroid function. Tests relating to the concentration and binding of thyroid hormones in blood. Metabolic indexes. Tests of homeostatic control of thyroid function. Miscellaneous tests. 1. Direct tests in vivo administration of radioactive iodine. Thyroid radioactive iodine uptake, RAIU, is the most common. RAIU is measured 24 hours after administration of isotope. Normal is 10 to 30% of administered dose after 24 hours. Values above normal indicate thyroid hyperfunction. 2. Tests related to hormone concentration and binding are radioimmunoassays. Highly specific and sensitive radioimmunoassays to measure serum T3 and T4. Highly sensitive TSH assay is the most sensitive of thyroid function. 3. Metabolic indexes. Although measurement of the metabolic impact of thyroid hormones have value in the investigative setting, none is sufficiently sensitive, specific, and easily performed for routine use. Measurements of oxygen consumption in the BMR were once a mainstay in the diagnosis of thyroid disease, but not today. 4. Tests of homeostatic control. Basal serum TSH concentration. thyrotropin-releasing hormone. Thyroid suppression test. 5. Miscellaneous tests. These do not assess thyroid function but are of value in defining the nature of the thyroid disorder or in planning therapy. Example: some patients with autoimmune thyroid disease develop circulating antibodies against T3 and T4, resulting in sporadic highs and lows in the concentration of the hormones. Hyperthyroidism. Clinical symptoms include nervousness, palpitations, intolerance to heat, weight loss, muscle weakness, and fatigue. Physical exam: smooth, moist skin, exophthalmos, presence of goiter, tachycardia, and hyperactive tendon reflex. Skin temperature is elevated, and there is fine tremor of the extended hands or a coarse tremor and jerking of trunk. Hyperthyroidism. Long-standing thyrotoxicosis. Mild anemia and lymphocytosis are common. Approximately 20% will have reduction in total WBC count. Hyperthyroidism affects approximately 2% of women and 0.2% of men. Causes of hyperthyroidism: Graves' disease, diffuse goiter and ophthalmopathy, is the most common. Graves' disease typically occurs in women 20 to 40 years of age. An autoimmune pathogenesis for Graves' disease is suggested by presence of immunoglobulin G autoantibodies. Causes of hyperthyroidism: iatrogenic, second most common cause, may result from administration of T3/T4. Toxic nodular goiter, nodules functioning independently of normal feedback regulation. Thyroiditis, inflammation-induced release of thyroid hormones. Treatment of hyperthyroidism: antithyroid drugs. Usual initial medical management: propylthiouracil, carbimazole, methimazole. These drugs inhibit synthesis of inorganic iodide and coupling of iodothioamines. Graves' disease often initially treated with antithyroid drugs in hope of inducing a remission or achieving euthyroidism before surgery. Treatment of hyperthyroidism: pregnant females should be treated with propylthiouracil. Of antithyroid drugs, it crosses placenta least, minimizing the risk of goiter any hypothyroidism in fetus. Serious side effects of antithyroid drugs include agranulocytosis. Intraoperative bleeding, from drug-induced thrombocytopenia or hypoprothrombonemia has been reported in patients on propylthiouracil. Hypothyroidism is a risk of antithyroid drugs, so patient may receive supplemental T4. Treatment of hyperthyroidism: beta-adrenergic antagonists. Useful adjunctive therapies for patients with Graves' disease diminish some of the SS, tachycardia, anxiety, tremor, more rapidly than can antithyroid drugs. Nadolol and atenolol have a longer duration than propranolol. These drugs do not block the synthesis and secretion of thyroid hormones. Treatment of hyperthyroidism: inorganic iodine. Iodine and pharmacologic doses: Lugol solution, 5% iodine, 10% potassium iodide in water, inhibits the release of T3 and T4 for a limited time, days to weeks, after which its antithyroid activity is lost. Inorganic iodine is principally used to prepare PTS, for surgery and treat thyrotoxic crisis. Treatment of hyperthyroidism: radioiodine therapy. Often selected as Texas of choice for hyperthyroidism that recurs following therapy with antithyroid drugs. Objective is to destroy sufficient thyroid tissue to cure hyperthyroidism. Permanent hypothyroidism is the only important complication of this therapy. Pregnancy is an absolute contraindication as it may cause ablation of the fetal thyroid gland. Treatment of hyperthyroidism: subtotal thyroidectomy. Used to treat Graves' disease when radioiodine is refused, or for rare PTS, with large goiters causing tracheal compression or cosmetic concerns. If elective, PT needs to be rendered euthyroid with drugs. In emergency, PTS can be prepared for surgery in less than 1 hour by 4 administration of esmolol. Treatments to render hyperthyroid PTS: Euthyroid prior to surgery. Emergency surgery. Esmolol 100 to 300 micrograms/kg per minute for until heart rate less than 100 per minute. Elective surgery. Oral administration of beta-adrenergic antagonist, propranolol, nadolol, atenolol, until heart rate less than 100 per minute. Antithyroid drugs. Antithyroid drugs plus potassium iodide. Potassium iodide plus beta-adrenergic antagonist. Subtotal thyroidectomy. Some uncommon complications include damage to recurrent laryngeal nerves, post-op bleeding into the neck with resultant tracheal compression, and hypoparathyroidism. Most common nerve injury is damage to abductor fibers of recurrent laryngeal. This injury when unilateral, harshness, and paralyzed vocal cord assuming an intermediate position, subtotal thyroidectomy. Bilateral recurrent nerve injury results in aphonia and paralyzed vocal cords. The cords can collapse together, producing total airway obstruction during inspiration. Selective injury of adductor fibers of recurrent laryngeal nerves leaves the adductor fibers unopposed and pulmonary aspiration a hazard. Subtotal thyroidectomy. Airway obstruction that occurs soon after tracheal extubation, despite normal vocal cord function, suggests tracheomalacia. This reflects a weakening of tracheal rings by chronic pressure of a goiter. Airway obstruction post-op, PACU, may be due to tracheal compression by a hematoma, subtotal thyroidectomy. Hypoparathyroidism resulting from accidental removal of parathyroid gland rarely occurs after subtotal thyroidectomy. If damage to parathyroids does occur, hypocalcemia typically develops 24 to 72 hours post-op, but may manifest as early as 1 to 3 hours post-op. Laryngeal muscles sensitive to hypocalcemia may go from inspiratory stridor progressing to laryngospasm. Prompt for calcium till laryngeal stridor ceases is Tixus. Subtotal thyroidectomy. Thyroid storm, thyrotoxic crisis. Medical emergency characterized by abrupt appearance of clinical signs of hyperthyroidism, tachycardia, hyperthermia, agitation, skeletal muscle weakness, CHF, dehydration, shock, due to the abrupt release of T4 and T3 into the circulation. Can occur intra-op but is more likely to occur 16 to 18 hours postoperative. Thyroid storm, thyrotoxic crisis. When thyroid storm occurs intra-op it may mimic malignant hyperthermia. Treatment includes cooled glycoids and continuous 4 infusion of esmolol to maintain heart rate at acceptable level, usually less than 100 per minute. When hypotension is persistent, the administration of cortisol, 100 to 200 mg for may be a consideration. Thyroid storm, thyrotoxic crisis. Propylthiouracil is given in dose of 100 mg every 6 hours PO or by NG tube to take advantage of the drug's ability to inhibit extrathyroidal conversion of T4 to T3. Potassium iodide is also administered to block the release of T4 to T3. Also important to treat any suspected infection in these patients, management of anesthesia. Elective surgery should be deferred until the patient has been rendered euthyroid and the hyperdynamic cardiovascular system has been controlled with beta-adrenergic antagonists, as evidenced by an acceptable heart rate. Management of anesthesia. When surgery cannot be delayed in symptomatic hyperthyroid patients, the continuous infusion of esmolol, 100 to 300 micrograms/kg per minute for may be useful for controlling cardiovascular responses evoked by the sympathetic nervous system. Management of anesthesia. Preoperative medication. A. Benzodiazepines. B. Use of anticholinergics not recommended as these drugs could interfere with the body's own heat-regulating mechanisms and contribute to an increased heart rate. Management of anesthesia. Preoperative. Evaluation of the upper airway for evidence of obstruction, goiter compressing on trachea, is extremely important. Be prepared and have available in the OR needed equipment for a difficult airway and difficult intubation. Management of anesthesia. Induction. Propofol/pentothal for induction. Ketamine is not a likely selection as it can stimulate the sympathetic nervous system leading to a tachycardia. 6-Anilcholine or non-depolarizers that do not affect the cardiovascular system for intubation, would avoid pancuronium. Maintenance of anesthesia. Goals in maintenance of anesthesia in patients with hyperthyroidism are: avoid administration of drugs that stimulate the sympathetic nervous system. Provide sufficient anesthetic-induced sympathetic nervous system depression to prevent exaggerated responses to surgical stimulation. Maintenance of anesthesia. Volatile anesthetics. Isoflurane, desflurane, sevoflurane, are good as they offset adverse sympathetic nervous system responses to surgical stimulation, but do not sensitize the heart to catecholamines. Remember sevoflurane and potential concern with nephrotoxicity caused by an increased production of fluoride owing to accelerated metabolism of this anesthetic. Maintenance of anesthesia. Monitor and keep track of patient's body temperature, keep in mind thyroid storm. Vigilant monitoring of vital signs. PTS. With exophthalmos prone to corneal ulcerations. For antagonism of neuromuscular blockade with anticholinergics, it is best to avoid atropine and use glycopyrrolate as it has fewer chronotropic effects. Maintenance of anesthesia. Treatment of hypotension. When using sympathomimetic drugs, must consider the possibility of exaggerated responsiveness of hyperthyroid PTS to endogenous or exogenous catecholamines. Therefore, decreased doses of direct-acting vasopressors such as phenylephrine may be a better choice than ephedrine, which acts in part by provoking the release of catecholamines. Regional anesthesia for hyperthyroid patients. Causes a sympathetic nervous system blockade. May be a useful choice in hyperthyroid patients, assuming there is no evidence of high-output congestive heart failure. Continuous epidural may be preferable to spinal because of the slower onset of sympathetic nervous system blockade. Regional anesthesia for hyperthyroid patients. If hypotension occurs, decreased doses of phenylephrine are recommended. Epinephrine should not be added to local anesthetics, as systemic absorption of this catecholamine could produce exaggerated circulatory responses. Hypothyroidism decreased circulating concentration of T3 and T4. Present in 0.5% to 0.8% of adults. Diagnosis based on clinical SS plus confirmation of decreased thyroid gland function as demonstrated by appropriate tests. Hypothyroidism. Causes. The etiology of hypothyroidism is categorized as primary, destruction of the thyroid gland. Secondary, central nervous system dysfunction. Chronic thyroiditis, Hashimoto's thyroiditis, is the most common cause. Etiology of hypothyroidism. Primary hypothyroidism. Thyroid gland dysfunction. Hashimoto's thyroiditis. Previous subtotal thyroidectomy. Previous radioiodine therapy. Irradiation of the neck. Etiology of hypothyroidism. Primary hypothyroidism. Thyroid hormone deficiency. Antithyroid drugs. Excess iodide, inhibits release. Dietary iodine deficiency. Etiology of hypothyroidism. Secondary hypothyroidism. Hypothalamic dysfunction. Thyrotropin-releasing hormone deficiency. Anterior pituitary dysfunction. Thyrotropin hormone deficiency. Hypothyroidism signs and symptoms: decreased metabolic activity. Lethargy is prominent. Intolerance to cold. Cardiovascular changes are often the earliest clinical manifestations. Bradycardia. Decreased stroke volume and contractility. Decreased cardiac output. Hypothyroidism, increased SVR. Systemic hypertension, especially diastolic hypertension, occurs in about 15% of hypothyroid patients. Narrow pulse pressure. increased circulating concentrations of catecholamines. Overt CHF is unlikely, but if present may indicate coexisting heart disease. Hypothyroidism. Patients with hypothyroidism are predisposed to pericardial effusions. The EKG may reveal low voltage, prolonged PR, QRS, and QE intervals due to pericardial effusion. Conduction abnormalities may predispose patients to ventricular tachycardia, especially torsade de pointes. Hypothyroidism. Thyroid hormone is necessary for normal production of pulmonary surfactant. Chronic hypothyroidism is associated with pleural effusions. Ventilatory drive to hypoxia and hypercapnia is decreased in patients with severe hypothyroidism. BMR can be decreased up to 50% due to the hypothermia that occurs. Hypothyroidism. Peripheral vasoconstriction characterized by cool, dry skin. There is often atrophy of the adrenal cortex and associated decreases in the production of cortisol. Inappropriate secretion of ADH can result in hyponatremia owing to the impaired ability of renal tubules to excrete free water. Hypothyroidism treatment: oral administration of T4. PTS. With ischemic heart disease and hypothyroidism may not tolerate even modest amounts of T4 without developing angina. If angina appears or worsens during T4 therapy, coronary angiography and CAP may be necessary before adequate T4 therapy can be achieved. Myxedema coma, rare complication of hypothyroidism. Manifests as loss of deep tendon reflexes, spontaneous hypothermia, hypoventilation, cardiovascular collapse, coma, and death. Sepsis in elderly or exposure to cold may be an initiating event. Myxedema coma. Treatment is with administration of T3, which exerts a physiologic effect within 6 hours. Digitalis, as used to treat CHF, is used sparingly because the hypothyroid patient's heart cannot easily perform increased myocardial contractile work. Fluid therapy is important, but remember these patients may be vulnerable to water intoxication and hyponatremia. Hypothyroidism management of anesthesia. Elective surgery should be deferred if symptomatic. T4 drug has long half-life, 7 days, and administration of it on day of surgery is optional. T3 drug has shorter half-life, 1.5 days, so it may be prudent to have PT. Take it on day of surgery. Hypothyroidism. Opioid premedication may be exaggerated in the hypothyroid patient. Supplemental cortisol may be considered if there is concern that surgical stress could unmask decreased adrenal function that may accompany hypothyroidism. Maintenance of anesthesia. Induction with pentothal, ketamine, or propofol. Tracheal intubation with 6-phenylcholine, or NDMR, but keep in mind that coexisting skeletal muscle weakness could be associated with an exaggerated drug effect. Maintenance of anesthesia. Often achieved with nitrous oxide plus short-acting opioids, benzodiazepines, or ketamine. Volatile anesthetics may not be recommended in overtly symptomatic hypothyroid PTS, for fear of inducing exaggerated cardiac depression. Maintenance of anesthesia. Vasodilation produced by anesthetic drugs in the presence of hypovolemia could result in abrupt decrease in systemic blood pressure. Pancuronium, because of its mild cardiovascular stimulating effects, may be selected for skeletal muscle paralysis. Intermediate and short-acting NDMRs are good as they are less likely to produce a prolonged neuromuscular blockade. Maintenance of anesthesia. Monitoring hypothyroid PTS during anesthesia is intended to facilitate prompt recognition of exaggerated cardiovascular depression, and detection of onset of hypothermia. Consider arterial line for long surgical procedures, or those associated with significant blood loss. Maintenance of anesthesia. 4 fluids used should contain sodium to decrease likelihood of hyponatremia. To treat hypotension it is best to use small increments of ephedrine 2.5 to 5.0 mg for. Phenylephrine could adversely increase SVR in the presence of a heart that cannot reliably increase its contractility. Maintenance of anesthesia. Suspect acute adrenal insufficiency when hypotension persists despite treatment with fluids and/or sympathomimetic drugs. Maintain patient's body temperature with use of a warming blanket or convection system, and warming of 4 fluids. Perioperative period possibilities. Increased sensitivity to depressant drugs. Hypodynamic cardiovascular system responses, decreased heart rate, decreased cardiac output. Slow metabolism of drugs. Hypovolemia. Delayed gastric emptying. Hyponatremia. Perioperative period possibilities. Impaired ventilatory responses to arterial hypoxemia or hypercarbia. Hypothermia. Hypoglycemia. Adrenal insufficiency. Postoperative management. Recovery from sedative effects of anesthetic drugs may be delayed. Tracheal extubation should be delayed until the hypothyroid patient responds appropriately and their body temperature is near 37 degrees Celsius. Due to increased sensitivity to opioids, may want to consider non-opioid analgesic. Extreme goiter. Goiter.